Everybody knows Erika Vlieghe as one of the main infectious disease specialists involved in the management of the COVID crisis. But in addition to her scientific skills, I would like to underline her full disponibility to help and kindly advise people facing highly contagious patients. As an example, one month before the COVID crisis, she fully helped us to fight against a patient suffering of hemorrhagic fever. And since the beginning, since 2014, when she was appointed as National Ebola Coordinator, Erika has always helped us in the fight of highly contagious disease in Belgium. And thanks for the work you did, and thanks to present today your talk on entitled Lockdown Exit Strategy from the Concept to the Reality. Erika, the floor is yours.
Okay, thanks a lot for the kind introduction, and thanks to all of you for can you hear me well?
Yes.
Yeah. Okay, perfect. Good. So I will start sharing my screen. Let me see. Okay. So right. Okay, can you see my screen? Yes, okay, perfect. So good afternoon from my side. So I'm an internist. I'm an infectious diseases specialist. Heading the Department of General Internal Medicine, Infectious and Tropical Diseases at the University Hospital in Antwerp. But I spent many years working at the Tropical Institute, and I did also my PhD research there. I'm actually working also. I'm connected to the University of Antwerp. And I'm still connected to the Tropical Institute as well. So with this triangle has been my professional life since 2005, more or less. And through this triangle, because in our hospital we are so closely linked to the Tropical Institute, that's how I ended up in this highly contagious diseases as National Ebola Coordinator. And once you're mixed up in this world, it's very difficult to get out. I noticed, and so that's how I ended up in this entire COVID response, which, as we know, is many ways more complex and complicated than the Ebola preparedness in Belgium was. And at that time, I was already quite busy and stressed, but this was nothing as compared to it now. I seem to be a bit of a chameleon in this scientific support of government services. We started in January, scientific committee. Then I was recycled into C-level, then recycled as a president of the DIS, and then into C-level 2, and so I'm actually also giving advice at the commissariat. I'm not sure whether this is a good or a bad thing, but this is real life, and I'm trying every day to offer insights and to join forces with all the other scientists which are there in Belgium, including several among you, because I strongly believe that we really need to keep united and exchange our ideas as much as possible. As you see on the bottom of this slide, I've written explicitly my conflict of interest, which is, I think, not extremely impressive. I think I was supported for travel costs to go to attend a conference last year, but I do this explicitly because over the past weeks, we as scientists have, from some corners, been under fire because of so-called conflict of interest. And I think I've never received any funding from Bill and Foundation, to my deep regret, because I would loved to have some proper funding for certain projects. But so far I'm relatively pristine in terms of conflict of interest, I think. So I'm here to share, and I'm very happy to share with all of you some insights, some very first and incomplete insights from the lockdown, from the exit out of the lockdown. As you know, last year a lot of things happened, a lot of phases. So this exit phase was only one of the phases of last year. So I would like, if I may, to go a bit earlier and speak a little bit about the first wave and how that brought us into this lockdown and exit strategy, and how that exit strategy evolved in what we are living now into the second wave, and how we should do it better now, hopefully in the next few months, and where we are heading to. Before I start, this is really a very personal story. Of course, it's a story of our country, but I mean, what I'm going to tell is my personal impression, and I'm sure that there absolutely needs to be much more research, also anthropological and sociological research on what is really going on in our society, and why the things happened as they were. But en attendant, this research, I think it will be interesting for all of us to try and explain already, okay, why do the things happen as they happen, and more importantly, how do we think to get out here, and how do we get again into smoother waters, in more quiet waters for our entire country. Okay. As a doctor, I recall this. If I think about this first wave, beginning of March, then this is really what I had in mind. I'm not sure how that is for all of you. And to be honest, I have a bit of similar feeling now today, especially when forecast of the hospitalizations of the next 2 weeks. Yeah, to be honest, that's really dramatic, but I think I'm not saying something really new. But maybe what made the first wave even more scary was that we had no idea what was really coming to us. And it really, for me, felt like I was on the prairie somewhere and I saw a very big tornado coming, and we had no idea what else could we do besides making sure that the doors and the windows were locked well, and that we had enough sardines and cans of beans, and I mean, of course, enough material, but there was very little time to really properly prepare. However, preparations had been ongoing already for several weeks, but only for several weeks and not for several months, let alone for years. And only during these preparations, we found out that several vital, important points, such as the of masks and other materials, was just not there. And that some other elements, such as a strategic plan for the hospitals, had been made, but was already outdated since 10 years and absolutely needed a refresher. So all that needed to be done in really fast forward modus. Because what we saw during this first wave was actually a progressive follow-up of several subwaves. The first wave was, as you all recall, a wave of relatively young and well-off people who had come from travels and who had then subsequently gone to their parents and grandparents. These people fell sick as well, and these were the ones that we started to admit already very fast in the process, already after the first week. We started to admit people without any clear epidemiological context, and around just a couple of days later, around the 10th of March, we started to observe the first outbreaks in elderly homes and in hospitals. So all that went very, very fast. And we saw also that, especially in Flanders, we saw a lot of cases. Limburg was very hardly hit, but in Wallonia we saw also that Hainaut was really hardly hit, and also Brussels was absolutely not spared. But this epidemic has been quite heterogeneous in terms of geographic um, intensity, and that is nowadays still the case, even though it's other provinces, it's other regions, etc. So all this went very fast. In a couple of days, we had a doubling time of only 4 days in this very early phase. So that was a very, very steep curve. We knew that in this very first wave, that we were focusing only on, let's say, the red and the orange blocks here in this pyramid, and that we had no idea at that moment of the big base of mild and asymptomatic cases. We could only guess how large that base would be, and as we know now, that base is very large, not only the mild, but also a lot of asymptomatic cases in there. So we were only able to focus on the fatal and the severe cases, which is a big contrast with the actual situation, where obviously we have a better insight, not a perfect, but a better insight of the base of this of our epidemic. We have now already somehow an idea on chains of transmission in the community, even though it's absolutely not perfect. And I immediately want to refer to the discussion of the cluster identification and where does transmission take place, and how important are bars and restaurants for transmission, etc. So, but we know already a bit more, we understand a bit better this epidemic, but it's absolutely not yet perfect. But what was driving us mainly in this first wave was fear for the total collapse of the healthcare system, because we observed that taking place in northern Italy. We all recall these dreadful images of collapsing healthcare services in northern Italy, and we thought, if that can happen in northern Italy, then that can happen with us. Moreover, because we saw the figures very, very quickly rising. And to be honest, that is again what we are afraid of now. And we really, so that was basically the main message, which I personally, but also many of our colleagues, sent to the politicians in the last attempt to control a bit the situation, which is evolving very, very fast. We have to start thinking what will happen if our healthcare system, which we are so used to rely on, if that collapses. And that is really the black line, or at least the red line. Okay, so that fear for collapse of the healthcare system has absolutely driven us as a scientific group, but also then the politicians who followed that advice into the creation of the lockdown, or the organization of the lockdown. And that seemed to be the only possibility to regain control over the situation, although we have to acknowledge that it was a very blunt and very, if I may say it in antibiotic terminology, a broad spectrum action. It was really blind carpet bombing, and one of the, carpet bombing, and we know that there is a lot of collateral damage in this carpet bombing. First of all, in the healthcare system itself, all routine medical care was interrupted. So we know that there was an important burden, an unmet need for untreated non-COVID pathology. But again, the situation was extreme, and if the actual situation now in our second wave, if we are not careful enough, we are heading again towards that problem. I think many of you who are working in hospital will agree with me on that matter. But also the economical life was largely interrupted, because without any distinction, nearly the entire B2B sector, but also shops and horeca, and the entire economical life was nearly interrupted. That was, to be honest, not only following the national decision, but obviously also because also all countries around us were installing some kind of lockdown, and so the entire international dimension was really under pressure, and many companies locked down by themselves because the entire context did not allow them to continue the production and their functioning properly. And then, of course, importantly, schools were also closed. Mainly, that was mainly a political initiative, not upon scientific advice. And so, as I may say, the pendulum really swung from the normal society as we knew it into something completely locked down without any activity, or the essential services that continued, something we'd never lived. And so the one extreme was, yes, we are very afraid and we need extremely strong and blind measures now. So that was one end of the spectrum. That lockdown has prevented the healthcare system from collapsing, clearly. So we stopped at 1,300 ICU beds that were simultaneously occupied. And so that we managed to remain under this limit of 2,000 beds, which is kind of the absolute limit so far. But nevertheless, that did not prevent a very, very considerable excess death. I think all of you are very well aware of that. And we know that an important proportion of this mortality happens in the elderly homes, and there has been a lot of analysis and discussions. I will not go through these details, although they are also extremely important, and we need to learn a lot from this. But in general, we know, of course, if we want to prevent deaths, that we have to protect the elderly, we have to protect those who have underlying comorbidity, and we have to protect the healthcare system, because we know that the more ad hoc beds and the more ad hoc overburdening of the healthcare system, the more that impacts also the outcome and the functioning of your healthcare system and the outcome. So there's this patient-based ways how you can prevent this mortality, but there's certainly also healthcare system-based elements that play the role in mortality. And so that is again where the lockdown may prove its importance, even though, of course, we need to see also the other side of that weighing scale clearly, which is the important burden of non-COVID pathology. Okay, so, and this lockdown was clearly felt as a blunt hammer, and I'm afraid that the measures that were taken yesterday are also some kind of hammer, but at a certain moment in an emergency situation, what you can do is only use a big hammer. It's like when your kitchen is completely overcrowded with cockroaches. There's no way of gently asking them to leave your kitchen. You just need to spray a lot of insecticides, toxic or not. But I mean, you need to bring down the burden, and that is what's happening now as well, or what should happen now. So first came the hammer, and the hammer was the only thing we knew at that moment. And then afterwards we said, okay, now we'll do things a bit more gentle and intelligent and pinpointed and etc. And so that from there came the concept, okay, now we've hit once very hard with the hammer, and afterwards we can do this. But I think we have, as a society, we have not yet learned very well how to do that. In the beginning, and I will not go too fast, but in the beginning, I think we danced a very slow and very cautious dance on a distance, but then that dance became a bit more like tango and salsa, and at the end of the day, now I think has evolved much more into some kind of capoeira, very wild dance, and I think that is probably not a safe dance anymore. So very nice theory, but society is not an individual, and we are learning now. We are paying a lot of learning money also to learn a society how to how to dance with the virus. It's very difficult, and I'm afraid this first try to dance with the virus went well for a couple of weeks and then become very challenged. So what's this all about? After the hammer, we are nearly on the top of the maximum of the cases. I received a phone call from the Prime Minister, then Prime Minister Wilmes, with the message: listen, I would like to generate a committee that focuses on the exit strategy. We need a clear exit strategy for Belgium, and I would like you to organize that. So the message was clear, but the answer was not really very clear how to do that. So we were 10 experts, 5 from biomedical side and 5 from state societal side, National Bank, CEO, or coordinator of social non-profit organizations, legal and IU expert. And all together, so we had numerous meetings in vivo and on distance meetings. I recall that period, so April, June, July, as very stressful, very intense, but now in retrospect, I think we were working in relatively epidemiologically, relatively curious situations, because figures were going down and we were coming down after the hammer, the big hammer of the lockdown. And we had a bit of time to think and to discuss and try and come up with a as good as possible multidisciplinary strategy. Quite a challenge, because obviously there's a lot of societal needs that need to be married with one another. But nevertheless, we organized ourselves in 12 work streams, 3 work streams that were really about what are the conditions that need to be in place always. So we data, protective material, testing and tracing, cluster analysis, etc. Then there were sector-based work streams, very focused on specific sectors and what specific protocols do they need to respect. And then we had other cross-cutting topics such as communication, juridical aspects, social impact, etc. So all that guaranteed us that forced us to really look at this exit strategy from different angles. And in 7 subsequent reports that we presented for the National Security Staff Councils, we bundled our insights. And so the idea was that as the hospital occupancy gradually went down, we needed to work very intensively to build the so-called first and second lines of defense that would protect us from sorry, let me restart again. So as hospital occupancy went down and with a low viral transmission, at that moment, due to the very strict measures and the hit of the hammer in the lockdown, we knew that we had a certain budget that we could use to reopen society. But we have, it's very difficult to know how big is that, and the budget is not endless. So you cannot open everything at the same time, and you have to do it in a very cautious way and in a stepwise manner. And you have to build in some safety nets to where the alarm can be raised and where you can have a guarantee that if things go wrong, if viral transmission starts up again, that it is absorbed by this kind of shock absorber. That was the idea, and that stepwise we would open certain sectors step by step in a very gradual manner, and that we would be able to monitor very clearly any resurgence in viral transmission and so on. So really, we had our key principles all together, and we presented them also as a clear strategy to the active government. We said, listen, this is going to be a very phased approach, and these phases need to be sufficiently spaced, 2 to 4 weeks, and we need enough data and up-to-date data to feed our judgment whether or not we can safely go from one phase to the other. And I think Marius Juli-augustus had also a presentation earlier this afternoon. And so I think he explained already quite clearly how we worked. We knew it needed to be a very balanced approach, where we absolutely try to keep where we try to keep all the needs in society, the healthcare sector, the economical sector, the schools, social well-being, and especially also the need to protect the most vulnerable, keep all of that very well in balance. And then, last but not least, there were certain conditions that absolutely needed to be in place. Otherwise, we said we cannot really start the exits, and that means the testing and tracing strategy needs to be up and running. There need to be the hospitals need to have enough. Otherwise, they cannot absorb the shock of a new resurgence. All kinds of protocols need to be in place and implemented and controlled. And we need a very, very good and clear communication strategy to explain this. So these were the conditions. And well, I would say you can judge for yourself how well the conditions were really in place and have been put in place. For some, we stressed more loudly and clearly, such as, for instance, the testing and tracing, that we have been shouting louder and louder and louder to have them in place. And for instance, for communication, we noted that every time in our reports, but nevertheless, it was never seen as a clear priority to have a unisono, very exhaustive communication strategy. One element that guided us always in the next steps were the data, of course. And at that moment, the main aim was again not to cause a new overburdening of the healthcare system. So that was the primary goal: open up society, but make sure that the healthcare system can continue to function and can continue to empty its beds so that the system can breathe again and can restart again its activities. Here is one of the figures, one of the first figures which Marius Gilbert designed, combining actually the absolute number of occupied beds and the growth rates of these beds, and that so that we knew gradually whether, when, and where we came in what we say the safe zone, the manageable zone, where we could gradually open up parts of society again. And so he made this, he produced this data each time before a new phase would be opened. And as you can see here on the opening of the B2B, so the large companies, gradually, and you see here in the red dots, we had gradually come down nearly into the safest zone. And so we said, okay, it's safe enough. That was already a hell of a job to all the companies waiting until the 5th of May until they were finally allowed to open up. And as you know, the opening of the shops, which was foreseen for at least 2 weeks later, was placed only 7 days later. There was no way how that we could wait, but we were still in a relatively safe zone. But then only 6 weeks later, we saw that after schools had reopened, the horeca had reopened, international travel had reopened, and we saw already that there was a certain stagnation which did not please us. So we knew that we had stagnated around 80 something patients, so cases. So that was, and if we look back at that figure, that was really a very nice figure to go back to. It would be really a dream. But nevertheless, that was low, but not low enough and not safe enough to to really allow for a long time an enduring way of opening society. Nevertheless, there was a lot of optimism in those days, and in early summer, as I said, everything was opened again. That was very fast, faster than we had foreseen, but it's like a tank. It's like it's a big machine. You can Tiananmen wise, you can try to stop that for a while, but not very long, and so that machine takes over again. And so the best you can do is do damage control and make sure that there's enough protocols. So we spent days and weeks in writing and discussing protocols. Trying to make sure that everything would happen in a very safe way. And all these sectors, they promised us that, of course, they would work in all the safest contexts, even the Horeca. They said, yes, of course, we will work and it will be safe and you will see, etc., etc. There was, all the sectors, also all the leisure sectors, asked us how should we open up. So that brought us into all parts of society, from the colombophile to the bridge clubs and the wind orchestras, etc. And some of these sectors was easygoing. There was not much risk, but some other sectors was really technical, such as indeed orchestras. But also certain sports. So there was a lot of work, and that led to an explosion of protocols, and with a lot of work to try and harmonize these protocols also between sectors, but also between both parts of the country. So that's a work which is still not yet finished so far. But already in that period, that optimism caused a lot of worries among us scientists, because we foresaw that there was too much enthusiasm and everybody was very fastly forgetting these protocols. Private life. Summer came, there was summer optimism, there were parties, marriages, people started traveling, and everybody wanted to forget these very, very tough and difficult times. And that's when we started, after this temporary low from between May and beginning of July, we saw a quick resurgence, first in Antwerp, following family parties, etc. And we saw this resurgence coming in. And so we called for action. And that was not taken well, because it was, nobody really felt like, this is too early, we have no time for this, we don't want this. But nevertheless, in Antwerp, the first line healthcare services cried out in fear and in panic, because they saw very fast increase of cases already in summer. So that's where the governor of the Antwerp province took strong actions. That is also the period where, at national level, everything was brought back to the sacred bubble of 5, which has been blamed a lot, but which either the message or the bubble or whatever helped to regain control over the situation, together in indoor settings and also in crowded outdoor settings. The installment of a night clock, the forbidding and blocking of large-scale events, and a lot of local communication. And I think the governor was cursed a lot for that, but in one way or another, in that province, they managed to control the situation there. So afterwards, it's very difficult to say which of all these measures that come in a package have done most. And maybe it's mainly the combination of all these and the sérieux with which they are being announced, and so severe interventions that are channeled in all layers of society, where people say, oh, whoa, maybe if they do that, then it must be serious, so then let's be careful, etc. So that flare-up was kind of decapitated and brought back under control, and so it was quite spectacular. But that was unfortunately only temporary, and people kept on traveling, coming back from many destinations, including destinations where already a second wave was taking place during summer. And I would like to refer to Bulgaria, Romania, the Balkans, And Spain, of course, because we knew very early in the process, Spain was already taking on, but they really wanted to probably to save their touristic season. At several other places, we knew that there was viral transmission ongoing. Um, for instance, over summer, we had these um, seasonal workers, often also coming from abroad, for instance, from Bulgaria, who came with or without the virus and who work and live typically in very crowded and not very safe settings. Same can be said about the meat processing industry. And so this mixed somehow also with further transmission in poor neighborhoods where there is intrinsically a lot of crowding, where a lot of ethnic minorities live who are often, where the messages are often not really reaching their people, etc. And then gradually also the young and the students um, um, restarted their life, but that was only later in September. Important contributed to ongoing and increased transmission were family meetings, and that's really very difficult because that belongs to all of us. And as long as these family meetings were taking place outside, in the garden, on terraces, that was relatively okay. But of course, once family gatherings start to be really crowded gatherings, referring again to family parties such as marriages, because that is really the typical potential place for super spreading events where generations meet, where also where you have intergenerational contacts, where you have close contacts, you eat, you talk, you sing, you dance, etc. So these are really very dangerous settings. And then, of course, with the new school year coming, or again, sports clubs taking on again, where transmission may take place during the sport activity, but even much more so afterwards, in the dressing rooms, in the showers, and in the canteens afterwards. So many possibilities and many different places. So this resurgence, this new second wave, the making of it was already in summer, and gradually it was not. I mean, we lacked really clear interventions and clear communication throughout summer. And then came September. And September, several important things happened in September. First of all, September is always the moment where people go back, children go back to school. And so it was laid forward as a clear societal priority, given the very negative experience of the school closure during the lockdown. And so that was really a message taken, okay, we will never again close these schools, especially not for these vulnerable younger ages. And so there was lots of discussion, and the decision that was made, okay, whatever it takes, but we'll try to keep open schools. But that means, again, budget, if you open the schools and you risk to have more contacts and transmission there, then you cannot with the same enthusiasm also reopen maybe your universities or have a lot of parties, have large scale events, have nightlife. All these things do not fit together because that will explode into new transmission of many more cases. And in the same time, people were also fed up of our strict messages, and so more and more a sense came like, oh, let's go back to normal. We shouldn't be so afraid. If the virus circulates a bit among the students and the kids, that's not too bad. It's not as bad as they say. And so the pendulum from blunt fear um, uh, swung back into the other extreme of, yeah, we are done with this, and we should just try to live with this virus. And that was also the task we were given in this syllabus, the new syllabus, which had also new composition, which hardly 1 out of 3 was a person with a biomedical background, and all the other people were with a societal background. So that was a real clear message, like, we don't want to hear anymore about any restrictions. We want just to know how to live with the virus. But that's quite a dangerous situation in retrospect, and we knew that already at that moment. And so we entered in a very difficult situation where you start where you have to start, dealing with an epidemic in a very challenged way. So that is gradually what happened, and when we saw that there was already gradually more and more transmission in society from different sources, as I've shown you, and the more and more transmission, then you know that these sources are coming together. And in the beginning, it was said early September, oh, but it's just because when you test more, you find more cases. But quite quickly, we noticed already that the net increase in tests was one thing, but the net increase in positive cases was much higher. So that was out of proportion. And so very soon we saw also that the positivity percentage, which was less than 1% at the end of June, was about 2 to 3% in September, and then gradually started increasing and is now about 10%. So that, the situation which we are in now. And so, unfortunately, we lost a lot of time for interventions and for preventive action to stop and to bring back this viral transmission to a more feasible, workable level by fighting the idea that this is not bad for society. And so that's how we entered into the fall, where we observe now an enormous increase in number of cases. In the beginning, it was cases, but after 2 weeks, we saw it also in the increase of hospitalizations. And in the beginning, that was just minor and modest, and that led to a lot of irritation from political sides towards us, scientists, saying, what are you guys talking about? This is only just like a couple of beds that are occupied and 70 people in ICU. That's nothing. But of course, just like the meteorologists can predict the weather, I mean, epidemiologists, they can also, and biostatisticians, they can predict an epidemic. And when you can see it coming when the figures are small, but when you ignore the small figures, then you're hit in the face by the big figures, and that is what's happening now. So now, when you wait long enough, this small number of hospitalizations will become bigger numbers of hospitalizations, will lead to ICU admissions, and will lead to increased deaths. That is just the epidemiological reality, such as we see it now. And so that's reality where we are now, with a fast increase in positivity ratio, with also big heterogeneity. And these data are already outdated for 2 or 3 days. But as you can see, there's now a north-south divide. And I saw already in the chat somebody who would like to know how I explain this north-south divide. It's a bit difficult to say, but we think there's multiple reasons for this. We in the first wave in March, we also saw important provincial differences. At the end of the day, infectious diseases always come back to behavior. That's where they start, and the behavior may have been different in several big cities, in French-speaking student cities. For instance, the end of September, I was in Namur. And I walked through the inner cities, and I saw all the students there happily partying, etc. No masks, no distance, etc. So clearly, the way how your young people behave, that influences the presence of your virus. And in the beginning, you will have circulation of virus only among the young and the young adults, but then gradually older ages will be affected too, because these students, they go home in the weekend and then they hug their parents and they don't keep distance from their parents. And so that spreads into older ages. That happens obviously everywhere in the country. But well, first of all, I think several higher education institutions in French-speaking Belgium started earlier, so have fallen earlier into that situation. Mainly also the hugging and kissing culture is more intense, which in normal times is very pleasant, but is certainly more dangerous now. So it's more, I think, also cultural, very difficult to keep distance, to reduce the number of close contacts. So that I think, honestly, but you can shoot me after this lecture. I think that there are cultural aspects that are more difficult to accept. And I think there has been a lot more polemics and discussions in the press, spreading the news that it's not all that very bad, and let the virus circulate among the students, etc., with the belief that immunity as such can come to the young and will protect the elderly, etc. All kinds of relatively dangerous strategies, I think. So what you see here is in the beginning, we saw an increase mainly among the young and among the students, and that was interpreted wrongly, like this is not so dangerous. But the problem is, in a society, you cannot make a clear distinction. You cannot shut out the young from the less young and from the vulnerable. In part, you can protect them, you can inform the vulnerable, but you cannot close them off completely because in a society we all live together, and students come back home to their parents and their grandparents. So there, that inevitably you have the situation seeping through, and that is what we see nowadays. So in the first wave, the elderly were really, really severely hit. So we are doing a bit better right now so far, but we know that also the elderly homes are not impermeable or not waterproof for this virus, because the younger people who work there, they may bring in the virus, and if they are not perfect in their hand hygiene, in their use of masks, etc. So the more you have virus circulation in the society, eventually it will end up with the most vulnerable, and that is what we start seeing in the hospitals now. And so all this evolution over summer and fall has brought us now into this unfortunate situation where Belgium is taking again the lead. We are the second worst hit country in Europe now, with the second highest incidence. That's also because we have such a small country, obviously. Very densely populated. We are only second to Czechia, so that's really not a very good position. And obviously, we are not an island within Europe. We know Holland is also having its troubles, France, Spain, but that does not preclude that we should take action. So 1st of October, we had a new federal government. 6th of October, they took first measures. Yesterday, they took more strict measures. Let's hope that that will be enough to control the situation. Because to summarize, we have in this, well, the lockdown, which was so blunt and had so much collateral damage. It's like an old-fashioned chemotherapy, which of course has a lot of side effects. And when you say, don't you have something more targeted and nicer and better? So we never want this again. But as a country, I feel we are like a bit like a cancer patient who has had a relapse of the disease and took a while to recognize that you have a relapse. And now in an emergency, we need to give, again, new chemotherapy. And that's unfortunate, because we could have given also maybe something more targeted, let's say in the beginning of September. So that's a bit unfortunate. What are ways out? So what we think as scientists, as a scientific community, we think we need to formulate clear goals, or we need politicians to formulate clear goals. It's not enough to say when things are a bit better, we can open up again. Be numerical clear goals, and they need to be formulated and communicated clearly to the communication. This barometer can really be a helpful tool for this. but we need a real all-inclusive communication strategy. We are asking this already since April. Let's do it properly now, and I hope new initiatives within the commissariat will help to do this. And we need also politicians who are not only doing reactive politics, but also preventive politics. Because if you wait long enough, like now, yeah, you can take measures, but you pay a big price. We all in the healthcare sector, we will pay a big price for this, I think, I'm afraid, but also economically. So, and that's really frustrating. This second wave, we could have prevented this, or at least in part, I think, and that's really very unfortunate. So what does the future bring? Well, let's see first how we manage to deal with this second wave. It's going to be a tough one, I'm afraid. So in Flemish, we say alle hens aan dek. And I'm afraid we will go more into these phases of stronger measures and then again a bit of more exit strategy. So we need to, that's why this barometer, I think, could be important for people to see where are we in the system and where are we going. We need to keep repeating clear societal goals, protect the health system, protect education, protect the economy, and see that the three of these are in balance. And what is the end point? Well, I think that will be, we'll probably need a combination of a vaccine and some kind of effective antiviral treatment. We're absolutely not yet there. So in the meantime, as a society, we'll need to strike a better balance than we do now, without all these peaks and valleys. So I think gradually, as a society, we will hopefully learn better how to deal with this. So to conclude, the first wave was really a walk over of our society, and we learned our lessons from there. The exits, that was really the theory, and then the political and societal reality. So we absolutely need to improve in communication, in harmonization. So these are exercises ongoing. And then the second wave, we saw it coming. There is a societal but also political background and context to interpret that. And as I said, it is a clear need for clear goals, communication, predictability, and also positive examples so that people know it's not enough to say you cannot do this and this and this, but it's also nice to show how could you do it. So because we all need a way to live with it. I want to leave it there, but if you allow, if time allows, I'm happy to try and answer some questions. Thank you for your attention.
Thank you very much, Erika, for this nice lecture and a very interesting point of view. I have several questions from the participant. Current studies indicate at least a temporary immunity after initial infection. Do you estimate that herd immunity will arise from the current large peak, or is the damage to get the herd immunity too great to accept?
Sorry.
Erika?
Could you please repeat?
Okay. What is your opinion in terms of about the herd immunity?
Yeah, that's a. And just to be brief, to be honest, I think we know way too little about that is provided the virus. This right now, to use it as a thing. And to be honest, we have no idea so far how long-lasting is the immunity really. And we know we can measure antibodies, but we know not enough of immunity to lean on this, and we absolutely need more insights. Okay, you have immunity, so it's try to spread the disease in a controlled natural way. I think that is the government at this moment.
Okay.
Can you summarize?
Thank you very much, Erika. I have one additional question. We decided to extend the autumn break till 11 November. Why didn't decide to start earlier, 1 week earlier, instead of to extend and to lose 1 week?
That, yeah, I think that the last, discussion at education with often in options between schools, the politics and us. The concept of the extent has been, that decision has been taken by the cabinet is French-speaking part, but not yet. There's also need for better organization. I think several hypotheses or possibilities. It is not yet that this autumn break is maybe taken forward of the actual measures has not yet been a choice against this. It's just, I think, so educational system for the secondary schools, but there is less transmission and probably
okay.
To use sports.
Thank you very much, Erika. Time is moving, and thanks again for all what you did since so many times in Belgium against infectious disease and to better prepare healthcare against new and re-emerging infectious diseases. Have a good weekend, and thanks a lot for your lecture.
No, thank you. Would you like me to send the slides somewhere, or we can do that over email?
No, yes. If you could send us the slide, it would be lovely. Thank you very much.
Okay.